I'm Dr. K. Sreekanth, Consultant Surgical Oncologist at Yashoda Hospital, Somajiguda. Has been in this field for the last 20 years. Today we'll take some questions on COVID related issues pertaining to the cancer surgeries or oncological surgeries. Cancer, I think, is a household term or a very common term what everybody is familiar with, and is a term which actually is known to cause fear and this thing among the family members once it's affected. But I think with rapid changes, progress and then advancements in cancer treatment, and definitely the hope for cancer patients is progressively increasing year after year, and we are seeing more number of cancer survivors nowadays when compared to those which was 10-15 years back. So in general, the body is nothing but accumulation of millions and millions of cells pertaining to different organs. So the body has a control mechanism where the cells divide in a particular way and then are destroyed in a particular way in a particular frame of time. For example, let us say the cell's span or the cell cycle of each organ is different. Let us say one cell has a survivor of about 10 days. After 10 days, the body automatically allows that cell to get destroyed by mechanisms which are signaling controlling pathways of the DNA in the cell, and a new cell is produced in that place. So roughly equal number of cells are destroyed or worn out, and then equal number of new cells are produced by the body. So this balance is kept in check by the checking pathways or control mechanisms which are there in the body. So cancer cells are nothing but abnormal cells which have got deviated or which have lost control from the normal physiological mechanisms, and they start doubling or multiplying in an abnormal way. Abnormal cells multiplying in an abnormal way without the control of the body's defense mechanisms. So these cells, they start multiplying, and then slowly 2 becomes 4, 4 becomes 16, 16 becomes 32. That's how they multiply and then form a mass or a lump. So this is the basic mechanism of cancer formation. So what leads to this cancer is any trauma or any insult to the cell. The cell has got a cell membrane, and then the DNA or RNA mechanisms in the cells which are actually have the signal control or controlling pathways. So when any insult to this signal controlling pathways by way of smoking or alcohol or pollution or many related insults to the cell, that cell signaling pathway gets damaged, and then it starts not having the control of the body's defense mechanisms or balance controlling systems. So once that control is gone, that damage is done, this cell divides uncontrollably and then becomes abnormal and then starts growing to form a lump which is called as cancer. So cancer and tumor. So tumor is nothing but a mass formation leading to a lump. So this mass formation is nothing but either formation of a normal cells which are grown beyond control, or formation of abnormal cells which have grown beyond control. So normal cells forming a lump is called as a tumor. So this tumor can either be an abnormal cells lump or a normal cells lump. So when a normal cells lump form a tumor, it's called as a benign tumor, and when an abnormal cells form a lump, it's called as a malignant tumor. So tumor and cancer are two different terminologies but closely interlinked. So tumors can be benign or malignant, as I told you. So benign tumors are generally harmless. So these generally what we see in benign tumors are examples of lipoma. This is a fat related lump. So the fat cells grow abnormally, but the cell is normal, but the multiplication of the cells are abnormal. So they are generally harmless. They grow, and then beyond a certain point of time they cease to grow and then remain like that. And other example is a neural tumors, what we call is a neurofibroma or a schwannoma. These are also benign tumors, they generally grow at the place where they arise and they do not spread to different parts of the body. So the benign tumors do not have a tendency to destroy the local organs, and then they don't have the tendency to disseminate or invade into the blood vessels or lymphatics and go spread to different parts of the body. Whereas malignant, some benign tumors are locally destructive in the sense they keep growing and they start causing compression on the adjacent organs or structures. Whereas malignant tumors, which are harmful, they are very aggressive because the growth rate is also rapid in them, and they also have tendency to invade into the blood vessels and the lymphatics. So these cells have they secrete certain substances which can actually destroy the blood vessels protective coating, or they have certain mechanisms wherein they tend to grow new vessels into the tumor. In that way they get the nutrition also, as well as they also help in spreading these cancer cells to different parts of the body in the bloodstream. So not all cancers form lumps, like as I told you, generally cancer is formation of lumps of abnormal cells. There are blood cancers like leukemias, myelomas, or all these hematological malignancies. In these malignancies, generally there is no formation of lump. All we see is abnormalities in the blood cells when we do a peripheral smear or bone marrow aspiration and biopsy. We find abnormal cells in these. So not all cancer cells form lumps, and not all lumps which are formed are cancerous. So they could be benign tumors as well as malignant tumors. Coming to surgery in cancer patients, first let us know what are the different stages in cancer. So cancer in general has got 4 stages: stage 1, stage 2, stage 3 and stage 4. So stage 1 and stage 2 are reasonably early stages in cancer, and stage 3 and stage 4 are reasonably advanced stages. So when we go from stage 1 to stage 4 is advanced, where it has spread beyond the confines of the origin of the cancer organ, and it has spread to different parts of the body. Most of the cancers require surgery. Most of the cancers, not all cancers, most of the cancers require surgery. Usually surgery is performed when the cancer is either first stage or second stage, or most of the third stages. So in late third stages or in certain advanced fourth stages, we don't prefer surgery. But even in certain fourth stage cancers, surgeries are performed to relieve the symptoms of a patient. Like for example, when the cancer can be in fourth stage, where a tumor or cancer in the intestine is blocked or obstructed, where leading to distension of the abdomen, and then unable to pass gas, unable to eat, constantly vomiting, and then a cancer where it has ruptured or where it has started bleeding. So even in fourth stage, we tend to operate on that, because the emergency here is to relieve the symptoms of the patient in last stages. So most of the time surgery is performed in stage 1, stage 2 and most of the stage 3 cancers, where surgery forms an important part of treatment modality. So, but in cancers like leukemias, lymphomas and then myelomas, the surgery is not the primary mode of treatment, and most of the times it's chemotherapy. And surgery is only done to take a lymph node biopsy in lymphomas, or nodal biopsy, or a biopsy from any abdominal glands, or in lymphoma or leukemias, it is basically placement of chemoport. So surgeries are just basically performed to either for diagnostic purposes or for facilitating a treatment modality by inserting a chemoport for chemotherapy in these blood cancers. See, as I told, the surgeries are usually performed in stage 1, stage 2, stage 3 and very few stage 4 cancers. But the type of surgeries what we perform varies from cancer to cancer and from organ to organ. But most of the times surgeries are performed on the affected organ. Either, for example, suppose you get a cancer in the breast, we tend to remove a part of the breast or most of the breast or whole of the breast, depending upon the local stage and local disease extent. But nowadays, most of the times we are trying to conserve the organ to which the cancer is affected. Like earlier, about 20-25 years back, I think if there's a breast cancer, I think the most important surgery was, the first thing was to remove the breast. But now we have come to a stage where the mastectomy rates or the complete removal of breast has come down to almost 20% or 25%. Most of the times we are trying to conserve the breast, because the results with conservation and removing the whole breast are almost same, and there's so much of psychological disturbance to the patient when we remove the whole breast. The same way, organ conservation procedures in bone tumors, where usually it affects young individuals or young children, adolescent children between 15 or 25 or 30 years of age, and when they affect the bone, earlier the only treatment option was removing the limb, either it could be the hand or the leg, followed by placement of an artificial prosthesis. Now, because of the advancements in chemotherapy and the medicines which started showing a lot of promise in giving the response rates, so we started using chemotherapy followed by limb preservation or limb conservation, where we have excellent prostheses, implants, where we use we can replace the bone with the metal implants. So the same way for soft tissue sarcomas, and same way for kidneys. Earlier, when there's a tumor in the kidney, the whole kidney used to be removed. Now the tumor is small and we can conserve, and the kidney is being conserved, but only a partial nephrectomy is being done. The same way, larynx, when the voice box is affected, earlier the only procedure was to remove the whole of the voice box. But now, if the stage is early and if the indications are there where we can remove the tumor with negative margin, then we are doing a voice preservation procedure. So we have moved from a radical surgery to a conservative surgery, and then the next advancements have been minimally invasive surgeries or laparoscopic surgeries, where long incisions and extensive opening of the abdomens or the thoraxes have come down now, and we are using instruments to manipulate and then remove the dissect and remove the tumors in the abdomen or in the thorax. And another advancement has been almost akin to the laparoscopic surgery, so robotic surgery, where the surgeon can sit at a console and then operate on a patient placed at a slightly at a distance. So these are all the different methods of surgical techniques what have evolved in the last 20-25 years, where only open surgery and extensive surgery or radical surgery was the norm 20 years back. And in this 2 decades, I think we have seen enormous advancements in surgical techniques, where the laparoscopic surgery or minimally invasive surgery have reduced though they might have increased the cost, but they've reduced the pain and the post-operative stay for the patients, and the comfort level of the patients and the compliance of the patient in the post-op period have definitely increased. HIPEC is not a surgery. HIPEC is hypodermic intraperitoneal chemotherapy. It is a novel treatment procedure or novel treatment technique which is applied generally to cancers in the abdomen, mainly for ovarian cancers where there is a proven role, and then colorectal cancers and mesotheliomas. So other than that, the role is not proven for gastric cancers or pancreatic cancers. So this is a technique wherein mainly we use it for ovarian cancers and mesothelioma, wherein after opening the abdomen from the chest to the pelvis, we completely remove the tumor, debulk the tumor as much as possible. So the idea here is the tumor has to be debulked to a microscopic level or to a level where minimal macroscopic residue is seen. So after debulking or removing the tumor completely in ovarian cancer or colorectal cancer or mesothelioma, then this HIPEC procedure is used, wherein the machine, which is called as used for the HIPEC, has a facility to heat up a sterile solution, and then the chemotherapeutic drugs are mixed into this solution. The common chemotherapy drugs that are infused into this solution are mitomycin, driamycin, or cisplatin, or very rarely paclitaxel. So these things not all the things are mixed at the same time. So depending upon the type of the disease, depending upon the response what the disease has got with previous chemotherapy treatment, the oncologist decide to use what medicine for the cancer. So this medicine is mixed in that sterile infusate or solution, which is run through the machine where the solution is heated up. Hyperthermia is nothing but heating up the solution to a temperatures of between 40 to 43 degrees. So this heated solution mixed with chemotherapeutic agents is run by a special tubings into the abdomen, and that cycle is run, that heated solution with the chemotherapy is run into the abdomen, all around the intestine, all around the spaces, all around the crevices, all around the folds for about 90 minutes or 120 minutes a cycle, or 45 minutes of 2 cycles, or 1 cycle of 90 minutes or 1 cycle of 120 minutes. This heated solution with the medicine gets absorbed by surface absorption and then destroys the cells, the cancer cells which are there on the intestines or on the intestinal folds or on the mesentery or on the liver, which cannot be removed completely by surgery, and destroys those tumor cells. So this HIPEC has shown some promising results by extension of survival in many patients, and I think when suitable, this has definitely added to the survival of the patients, wherein earlier days the patients used to die early. Now we are able to extend the lifespan of these patients to a reasonable extent. I think it's a very difficult decision to be taken by either the oncology surgeon or the hospital administration or the in charges. But the most important thing here is we have to weigh the risk of delay versus the benefit when we take a decision whether to operate or not to operate in the lockdown. So if the criteria meets, the risk of the delay is going to make a curable cancer to incurable cancer, then definitely I think we are justified in operating during lockdown. COVID-19 is a pandemic as we are experiencing now, and a lot of resources needs to be available during this pandemic time. What I meant was we need a lot of beds being available, both normal as well as the ICU beds as well as the critical care beds, and a lot of ventilators needs to be available in fighting this pandemic. So all the resources cannot be drained now at this critical time when it is needed to be used for COVID-19 cases. So what I meant was elective surgeries should not be planned during this time because the resources are limited. The doctors, the paramedicals, the nursing staff, the lab technicians, the ICU beds, critical care beds, everything are limited, and suddenly if they say exponential number of patients getting admitted, then we really don't have beds to accommodate them. So elective surgeries like total knee replacements, tonsillectomies, certain mastoidectomies, so all those things which can be waited without any risk to the patient have to be withheld during these times. But cancer is a disease where delay of not operating or not treating can actually cause cancer to go or progress from stage 1 or stage 2 to stage 2, or if it is stage 2 cancer, it will go to stage 3, or if it is stage 3 cancer, it will go to stage 4, because cancer keeps multiplying. The more the time we give for these cancer cells, they start multiplying and then being stationed at the same place to the organ where it has developed, it is okay to an extent. But when they start multiplying, they start getting into the blood vessels or the lymphatic. So that's where the more danger comes. So I think if the risk of waiting is more than the benefit, then definitely I think we are justified in operating these patients. But I think before any operation is performed on cancer, even on a cancer surgery patient, I think the most important thing is to screen them. Screen them, like take a history of any travel, take a history of any contact with any of those patients who traveled or any of positive patient, and then history to rule out whether they are coming from a red zone, orange zone or a green zone, and then history of symptoms like throat pain, fever, dry cough, and preferably if the private the testing kits are available in the private sector or whichever sector, if a patient whoever is going for surgery can undergo a PCR testing or a throat swab and then wait for a day, see the result, and if it's negative, then if you take up the patient, I think this is going to give a lot of safety to the doctors, to the paramedical staff, and to the whole of the medical fraternity. If it is negative, then I think we can safely go ahead with surgery, provided we can take the history and do the testing before the surgery. See, cancer is a disease which is generally comes into category of semi-emergency. Cancer has got a peculiar feature of what we call as doubling time. So you give time, it doubles. So the doubling time varies from one cancer to one cancer. Like lymphomas or leukemias have got the highest doubling time. They've got the highest doubling time, fastest doubling time. They start dividing in hours or days. That's what we tell. So most of the cancers have got a doubling time of days or weeks. So when this sort of a feature is so peculiar and so aggressive in pertaining to cancer, waiting for a week or two is okay, but beyond that, what happens is a cancer which is in stage 1 can become stage 2, or which is in stage 3 can progress to stage 3, stage 4, which is dismal. The prognosis is very dismal when it goes to stage 3 or stage 4. So giving some time is okay, but beyond that time, I think it is not permissible for us to wait for the pandemic to get over, because see, this COVID-19 is a new virus, and we are still trying to analyze and then figure out the physiology, the characteristics of the virus, the duration of, what is the treatment modalities available for the virus, how to contain the virus. So nobody knows when this pandemic is going to end. Ultimately it is in our hands, how to cut that chain of progression from one person to one person. So I think it doesn't justify pertaining in terms of cancer surgeries to wait for the pandemic to get over, because there have been analysis and predictions and calculations that this might get over, this might phase down or flat down worldwide by this year end. So I don't think we can wait, give that sort of a time for the cancer patients to undergo surgery. So I think we have to move on with this pandemic. We have to move on with this COVID virus, understanding the nature and the characteristics of this virus. So taking all the precautions like social distancing, hand hygiene, and avoid touching nose, face, and then eyes in public places, and taking all the precautions, we have to move on and then go ahead with surgeries. And definitely we cannot wait for the surgeries to be held on till the pandemic gets over. So this continues till a concrete treatment or concrete medications or medicines or vaccines are developed for it. So we have to move on with the COVID and then perform surgeries, taking all due precautions and giving due respect to the virus as well. So the ending of pandemic is basically driven by the humans and by the cutting the chain of progression from one person to one person. So while operating on cancer patients, I think all the protective measures needs to be taken, like wearing an N95 mask and then wearing the protective gear, and not only for the doctors but also for the nursing staff who are assisting or who are involved in the operation, and then minimizing the operating time. So finish the surgery as soon as possible. That doesn't mean that you should compromise the safety of the patient, but try to minimize the operating time so that will maximize the safety profile, safety zone for the surgeons, for the nurses, and for the anesthetists who are involved in the operating team. And also try to use this high pressure respiratory facilities which are there, especially designed for the operating rooms, wherein whatever the aerosolization is happening, I think they can be sucked out by the high pressure respiratory devices which are placed in the operating rooms. See, all the patients who undergo surgery, especially cancer, are at high risk of contracting this virus because they would have been exposed to chemotherapy, which will again reduce their immunity levels, and or all cancer patients, usually cancer affects patients in their age when they're more than 50 or 60 years. most of the patients are aged. So the defense mechanisms or immune mechanisms are generally lower in this age group when compared to the younger age group. So they are more prone to contract or get this virus because of the post-operative status where the immunity is low, because of the cancer status in whom generally the immunity is lowered because of older age, and then most of the patients or few of the patients would have undergone chemotherapy wherein again the defense or immune systems are lowered. So the thing actually is, all the protective measures which we advise for the routine breaking or the transmission from one person to one person has to be strictly followed in the post-operative period. Like the attendants who are there with the patients should strictly follow the hand hygiene and the social distancing. They should wear N95 mask or the triple layered surgical mask, and should avoid a lot of attendants coming in to see the patient. And the attendant or the patient person who is there next to the patient should not be going out frequently and coming down. For example, commuting every day from the hospital to the home and then coming back, or from the hospital to some other place and coming back, is definitely not allowed at this point of time. So taking the same precautions what is needed to contain or break the transmission of the virus should also be followed in the post-operative period after the surgery is performed on a cancer patient.